Okay, so recall that the previous section ended with, given the inconclusiveness of this inquiry into the patient's previous attitudes and present behavior, her caregivers might reasonably shift their focus of attention away from the patient's elusive subjectivity and toward a more objective assessment of her best interest. All right, so the best interest standard. In the absence of reliable indicators of the patient's actual or hypothetical preferences, courts and commentators have recommended an inquiry into the best interests of the patient. What course of action or inaction will bring about the best overall result for the patient? Rather than finding this objective path an easier route to the correct decision, caregivers attempting to apply such a test to the case of a severely demented, minimally functional patient, such as Mrs. Smith, will immediately confront a series of equally perplexing questions. Okay, so just to be clear here, in this first main section, after we got our description of Mrs. Smith, probing the patient's subjectivity, there we were trying to figure out, or we were looking at these methods of trying to figure out what the patient wants. So, in a sense, internally, what are the patient's wants and desires? Of course, for someone like Mrs. Smith, she can't express her wants and desires in the same way that we can. And so figuring out what she wants, as we found, is a problem. But that whole procedure is what Arras is referring to as an inquiry into the patient's subjectivity. Now here, rather than trying to figure out sort of internally what's going on with the patient, what the patient wants, the idea is we'll just stand back and consider the benefits of the treatment to the patient, the burdens that the treatment will entail or impose on the patient. And so just by looking at those factors, weighing those factors, we'll figure out what's in the patient's best interest. Now, of course, we would hope that what the patient wants subjectively and what we objectively figure out is in the patient's best interest will be the same. But the thought is, since we can't really figure out subjectively what the patient wants, this objective method is going to be better. Although, as I just read, Arras says, rather than finding the subjective path an easier route to the correct decision, caregivers attempting to apply such a test to the case of a severely demented, minimally functional patient, such as Mrs. Smith, will immediately confront a series of equally perplexing questions. What will be the actual impact of placing a G-tube on Mrs. Smith's well-being? What definition of the good will ground their assessment of her best interests? And given her low level of functioning, is it quite accurate to even describe Mrs. Smith as a full-fledged person with actual discernible interests? Okay, let me go back here. So there are two important themes in this article. One, of course, is how we should make decisions about continuing life-sustaining treatment for patients like Mrs. Smith. The other theme is what is required to be a person. Okay, so it may not have occurred to you that there's a difference between being a person and being a human being. There is, although in most cases the two concepts will overlap. But for a human being like Mrs. Smith, the two concepts, person and human being, do not overlap. As long as she lives, she continues to be a human being, but at the point that we encounter her, she has ceased to be a person. Okay, and then that's discussed on 940 and 941. Okay, so is it quite accurate even to describe Mrs. Smith as a full-fledged person with actual discernible interests? Since these excessively difficult questions lack intuitively obvious answers, perhaps the best way to proceed is to examine categories of patients on either side of Mrs. Smith on the continuum of incompetency. Categories that do yield fairly firm moral intuitions, and then attempt to locate a proper response to her case by means of moral triangulation. Okay, so what we're going to do is look at someone who functionally is worse off than Mrs. Smith. That's going to be Mrs. Jones, who's in a persistent vegetative state. And then we're also going to look at someone who's functionally somewhat better off than Mrs. Smith. That's Mr. Black. So the idea is it's relatively easy to arrive at an answer about continued treatment for those two patients. Maybe that moral triangulation will give us some insight about Mrs. Smith. Needless to say, the clarity and distinctness of these idealized categories often become somewhat blurred in real clinical situations, that is, Mrs. Jones and Mr. Black. But there is still considerable theoretical value in discussing our responses to clear-cut cases. Okay, patients in persistent vegetative states. What if, instead of being minimally functional, Mrs. Smith were completely non-functional? We shall call this hypothetical patient Mrs. Jones. What if, instead of slowly declining into a twilight of consciousness, she were to have experienced a protracted period of anoxia that consigned her to a persistently vegetative condition? Okay, anoxia is being cut off from oxygen. So in particular, her brain for some period was not receiving oxygen, which means that although she's still alive, Mrs. Jones would subsist on brainstem activity alone. Her neocortex, the physical substratum of her capacity for consciousness, having been completely destroyed. She would thus persist in countless sleep-wake cycles, unable to connect with the world and with her past through conscious awareness, unable to plan or hope for better circumstances, unable even to perceive pleasure or pain. What rights, if any, would Mrs. Smith have, and what duties would be owed her by caregivers? Okay, so again, just to be clear, and maybe you know this, someone who's in this persistent vegetative state, the cortex is now just dead tissue. It's completely non-functioning. So the brainstem is functioning, and we get heartbeat, lung function, but even in the broadest sense of mental and psychological, there's no longer anything going on for these patients. If we were to apply straightforwardly the best interest test to the case of Mrs. Jones, we would be hard-pressed to discover actual interests that could be meaningfully imputed to her, that is, assigned to her. Lacking consciousness, she lacks a conception of herself as a moral agent with real interests in continued life and in the pursuit of her own vision of the good. Lacking the ability to experience pleasure and pain, she cannot be physically benefited or harmed. Indeed, as several commentators have pointed out, her only remaining interest in staying alive is based on the minuscule possibility that she has been misdiagnosed and could possibly regain some degree of consciousness in the future. Apart from that slimmest of chances, she has no interest that might be assessed through the best interest test. If we seek a solution to the problem of Mrs. Jones in examination of her best interest, we discover the paradoxical result that her best interest will probably be served by further treatment. True, except for the possibility of misdiagnosis, she cannot be benefited in any way by continued existence, but her lack of capacity for conscious experience renders her equally incapable of being harmed by further treatments and the extension of her life. Okay, so we're weighing the benefits and the burdens of continued treatment. Since she's in a persistent vegetative state, there's really no burden to her by just lying in the bed there and receiving artificial nutrition. There's not really any benefit either, but this slim possibility of misdiagnosis moves the needle a little bit so that the benefits outweigh the burdens. Thus, we cannot say, as the best interest test would appear to require, that Mrs. Jones is being excessively burdened by her treatments, or that she would be better off dead. This result is indeed paradoxical, because if anyone's life need not be maintained, one would think that patients in persistently vegetative conditions must be at the top of the list. Given the vanishingly small likelihood of misdiagnosis, especially after the passage of several weeks, I would argue that it is ethically appropriate to treat all persistent vegetative state patients as though they had no interest either for or against treatment. Okay, so then if we do this, the benefits are zero, the burdens are zero. Since continued medical interventions cannot realistically be thought to benefit them in any way, since caregivers cannot realistically be thought to have duties towards patients who cannot be helped or harmed, and since such treatments entail considerable costs, including the expenditure of huge sums of money, the time and energy of caregivers, and emotional strains on survivors, they may be ethically foregone. That is, these life-sustaining treatments may be ethically stopped. The important lesson here is that although a rigorous patient-centered best interest test might be ethically appropriate in most cases involving incompetent patients, it cannot be meaningfully applied when the patient under consideration lacks all fundamentally human capacities. In cases such as this, a judgment in favor of non-treatment must be based not on an objective weighing of benefits and burdens to the patient, for such patients are capable of neither benefit nor burden, but rather upon a judgment that the patient has ceased to be a person in any meaningful moral sense. Once this determination has been made, it is then ethically permissible to consider the financial and emotional impact of continued treatment upon other interested parties. Certainly, some families will, for religious or other personal reasons, continue to request life-sustaining treatments for their persistently vegetative relations, but others would be acting ethically to request the termination of all medical care, including artificially administered food and fluids. Marginally functional patients. On the other side of Mrs. Smith are those patients who might usefully be described as marginally functional. Okay, so what do we have here? Just persistently vegetative states is on the one side of Mrs. Smith. Marginally functional is on the other side, and recall that she is minimally functional. Okay, so Mr. Black, for example, is a 90-year-old man presenting with rectal bleeding and suspected colon cancer who refuses a laparotomy, if I'm saying that right, to confirm the diagnosis. Okay, so this is a surgical procedure to confirm that he has colon cancer. I have lived a good life, he says, and I don't want any surgery. His daughter, to whom he appears very close, concurs with his decision. Although Mr. Black appears on the surface to be sufficiently competent to make this decision, subsequent examinations by liaison psychiatrists reveal a glaring absence of short-term memory and significant confusion about his medical diagnosis and surroundings. He is described as pleasantly demented. Although patients like Mr. Black are strictly speaking incapable of rational decision-making most or all of the time, they differ from Mrs. Smith in their ability to reason, albeit poorly, in their ability to relate to other persons, and in their capacities to experience emotions, pain, and pleasure. Okay, so they can do all these things: reason, although not well, relate to other people, see someone they recognize, somehow interact with them meaningfully, experience emotions, and experience pain and pleasure. Notwithstanding their inability to make most healthcare decisions, these patients are clearly persons with a multitude of interests that can be advanced or frustrated by their caregivers. In spite of their deficits and relatively low quality of life, such moderately functional patients have every right to a patient-centered best interest analysis. While invasive, painful, and risky, surgery may or may not eventually be deemed to be in Mr. Smith's best interests. His capacity for experiencing the world are sufficiently intact to rule out any thought of foregoing other sorts of life-sustaining therapies such as artificial nutrition and hydration. Okay, so we're looking at the benefits and burdens of treatment for Mr. Black. It's clearly going to be the case that life-sustaining treatment, continuing to receive artificial nutrition and hydration, is in his best interest. And it's an open question. It would require further analysis to determine whether or not the surgery is in his best interest. But the important point for us is that it is in his best interest for someone in his state to continue life-sustaining artificial nutrition and hydration.